It does make me wonder, because obviously if it OTs, because to me, like in Australia, that's where OT fits in mental health. If it's, and I know OT is not really big at all in mental health over there, so it makes me wonder, one, if that particular service is being delivered at all, or two, if it's being delivered by another profession,
I
it
think
really
so.
should be delivered by an OT.
Hey, healthcare providers, you're listening to the Burnt Out to Lit Up podcast. Hosted by myself, Erica, and my husband, Michael. We're an OT-PT team that understands the healthcare industry's got some serious issues.
Inspired by our own experience with burnout, we've made it our mission and passion to help you navigate your career in healthcare by cultivating wellness, growing both personally and professionally, and advocating for a better workplace.
Whether you are a clinician or manager, new grad or seasoned vet, join us each week as we share interviews, research, stories, and strategies that will give you the tools to go from burnt out to your most lit up self.
Let's dive in. We have an awesome, interesting episode today for you. Something that you may not hear a whole lot of is the perspective from someone who lives outside the United States, looking in. We have Brock on the show today, who is an occupational therapist in Australia.
The land down under.
Oh, God. You had to do an accent.
I come from the land down under.
Jeez, I'm sure he'll be thrilled to hear your lovely Australian
That wasn't
accent.
an accent.
No.
Like, I can't do accents.
Just your lovely singing voice.
I come from the land down under. Da-na-na-na-na-na-na-na.
Is the guy who sang that song even Australian? Like,
So there's two songs that get me. It's that one and Toto's Africa.
Yeah.
One of my favorite songs of
Less
all
relevant, but
time. God bless the rains down in Africa.
okay. Anyway,
This is not a singing show.
what was cool about having Brock
cannot
on
sing.
is that we talked about the Australian healthcare system a little bit. We talked about OTs in Australia and their roles, which they do a lot more stuff in mental health, which is really cool to hear about, which is something that I don't think as many OTs do here in the States.
Yeah, this conversation is a different one, completely different from things we've had talked about and people that we've had, just because we're looking at two different countries, two different systems, and the emphasis on mental health there is much more than it is here in terms of OT. And it's really good. I'm just Brock. We developed a friendship with him. I'm on his show. He's on our show. He is a cool guy. He was talking to me about the huntsman spider that's in Australia, and I just got chills down my spine. Google the huntsman spider.
I think it's largely a myth that they have
It's not a myth.
epically big bugs all over the place, though. I mean, yeah, the huntsman spider, I think he was saying it's big, but I mean,
He says they're good to have around the house because they will. Oh my God, I have chills in my. They're so. Google it, please.
pretty gross looking.
It's. Oh my God. Like, he said they're good to have in the house because they'll eat the flies and the other bugs. But I mean,
I'd rather
it's
have
kind of like
flies.
I'd rather have flies. I can't think about it. What? I'm so weird. I think I have arachnophobia.
I would say it's definitely. And you have roachophobia.
I'm actually allergic to the American cockroach. I'm allergic.
How would they? Who tests for that?
So when I got my allergy test in my back, all those little
Yeah.
things they put on my
Little
back,
pricks.
we were seeing if I had any food allergies, which I don't. I'm allergic to dust, mites, the American cockroach. I'm allergic to certain species of palm tree.
What about it are you allergic to, though? Because usually it's like, okay, if I'm allergic to dogs, I'm allergic to like pet dander. But if it's roach, it's like, what is it?
But I don't know, and thank God I've never had to find out.
Because roach, like, they're not like, they don't have poison or anything, do they?
I don't
like,
know,
if they bite you-
Mike. I don't want to think about it.
What? It was like 2 or 3 in the morning one night, and I
Oh my God! You're gonna tell this story.
yeah, so I sleep like a rock usually.
Adios,
and,
mio.
And Erica goes into
the
the bathroom. She pees like all the time. It's like kind of crazy. Anyway, it was like middle of the night. She goes in there, and
We have a nightlight in the bathroom,
Yeah.
so I'm just there, middle of the night, not paying attention to anything.
like I wake up to this screaming, and Erica,
Oh my
there was a
God.
roach in the bathroom.
I saw this shadow approaching me. And I thought it was just my own shadow. I see something on the floor and it's moving. Oh, and all of a sudden, like, I could have not paid attention to it because it's the middle of the night and I'm half asleep. But something about it, like, instinctively, I felt it was a roach.
Yeah, so there I am, 3 a.m. Erica's, like, cowering in the corner. And I have to, like, have this epic battle with a cockroach to try to catch/kill it. It was a rough night. Because they're so, like, so elusive.
Oh my god. I don't want to talk about it.
They can, like, get under things
stop.
and, like, climb and
even you
trap it.
You go in there. What? I asked you how.
I ended up having to turn the shower on, like, because it had, like, run into the shower.
My ears are covered.
And Erica's eyes, well, I don't know why your eyes are closed. You can see what I'm saying. No, it was the only way I could, like, defeat it. It was like, it went in the shower and I'm like, oh, I got you now, you little son of a bitch. Turn the shower on. And that's how I won. It was like Gandalf.
Oh my god, okay.
It was like Gandalf in the Balrog.
No one even knows what you're talking about. No one watches Lord of the Rings.
Everyone watches Lord of the Rings.
Not me.
You know, with Gandalf, like, you think he dies after the first movie?
Mike, I don't even remember the movie. I don't care. I don't remember.
We gotta watch it.
We have very different interests.
You shall not pass.
No, I don't.
You absolutely know that.
No, I don't know that. Mike, I do not watch these movies that
was
you
me,
watch.
like, trying to keep the cockroach from going out the door.
No, but I asked you how it was going. Because I was in the bedroom and I know you're in the bathroom trying to get this thing. And I asked you, how is it going? And you said...
It's good.
You said something.
It's going.
You said it's bigger than the devil itself. Did you say something like that? You said something weird.
Doesn't sound like something I would say.
No. I'm totally forgetting what you said. But Brock said in Australia, there are big bugs, but they're not, like, most of them are in the outback. The Outback.
In the Outback Steakhouse?
No. But the huntsman spider is just very big, but it's very harmless. He says, like, there's actually some way smaller spiders to be afraid of. I'm afraid of any spider, but, like, when you Google this particular spider, guys, you're going to see that even though it's harmless, es que no lo quiero. I don't want it around. I don't care if it's, like good for the household. Oh my god. And he's like, he'll say that it's in the corner and his wife is afraid and he's like, it's not gonna do anything. I'm like, my god,
it's gonna build a web in your hair.
I know, don't talk to me.
Anyway, Brock has some awesome insight into OT in general. He has a podcast called Occupied. If you're an occupational therapist listening to this show and you want to head over and check out his show as well, it's got some good stuff on there.
Yeah, I didn't realize how small. I mean, I know how small this community is, OT, PT podcasters. I know PT podcasting is a little bigger. But he was telling us how, like, because of podcasting, we're getting, like, I forgot what he said. It wasn't in the episode, I think. This was just after the episode. We were talking about how recognized he's getting in the global community for his podcast. I'm like, wow, that's pretty cool.
Interesting. Yeah, it's a real easy way to connect with people who are doing the same stuff as you.
Yeah, and he's pretty laid back, and that's what makes it so great, and that's why we connected so well. Because although we are an OT and a PT, and although we talk about OT, PT things on our podcast, it's pretty obvious that we're just ourselves on this podcast. We're not our professional selves. This is more of like just us being personal.
I'm wearing pajamas.
Oh yeah, I'm wearing my sweatpants.
We actually get into health insurance, healthcare. They have universal healthcare and private insurance in Australia. That was an interesting thing to get into because, it's a hot topic here in the States.
We try not to be bitter. We tried not to be bitter about our current healthcare state.
Their better healthcare
in the
system.
U.S. Yeah.
Anyway, hope you enjoy the interview. You have anything else to add?
Would you rather go to Australia or New Zealand? If you had to pick one.
That is a pointed question because Australia and New Zealand, they have this rivalry. And we didn't get to talk about this with him at all.
So one of my close friends, Jen.
Yeah.
Her dad's from New Zealand. She's been to New Zealand, no lie, 24, 25 times every year of her life. But she's never been to Australia. There is a rivalry between Australia and New Zealand.
Apparently there is. We talked to someone on a cruise not too long ago about this. It's kind of like a little rivalry. I don't know. I want to go to both places. New Zealand seems like a little more like mountainy and green. Australia seems a little more like, obviously the center of the country is like mostly dry and desert, which is like both can be like beautiful as well. I don't know. I want to go see both.
Look, I want to see a kangaroo. I want to see a koala. I want to see other marsupials. I had an obsession with marsupials in high school.
Who has a marsupial obsession?
Me.
Oh my God.
I love marsupials.
Such a special girl.
If you haven't figured that out, no, you figured that out a long time ago. I'm very special.
You're a special one.
Marsupials.
Yeah. Before you listen, head over to wherever you're listening to this podcast
Rate,
and give
review,
us a rate,
love us,
review, show some love. That would be really neat if you would do that. That would help us a lot more.
Yeah, like we always, every time someone says that to me in a podcast, I'm like, yeah, I'll do it later. And then I don't. And then I stop, I pause, and I realize how important it is to get feedback. So I try to give as much feedback as possible when I listen to any podcast. When you think about things, like it takes a few seconds, maybe a minute or two out of your time. You could do it while you're in line. You can do it when you're...
Yeah, anytime, really.
Yeah.
If you're feeling ultra uber generous...
You love us that
and you
much.
love us that much. Honestly, if you're finding some benefit from the podcast, I mean, we've done our job, and that's what we want to do for everyone. We want
to keep doing our job.
Yeah, we want to be able to keep doing that, and part of the way that we're going to keep doing that is we opened up a Patreon not too long ago. Patreon is a great way for people to donate a couple bucks to their favorite content creators in exchange for awesome rewards. We're doing some exclusive episodes for Patreon donators now, things that you can't get on your normal platform. So if you want to get some more of us, or if there's some other great rewards too, head over to the website and see what they are. Patreon, patreon.com/burntouttolitup. Give it a look.
Mm-hmm.
All right, enjoy Brock.
Enjoy.
You hear teeth chattering. Sorry.
It's really cold in here. We need to put the heater on
cold.
for the first time. Yeah. It's probably not that cold. We're just weak.
On the mic's like right in your face.
I'm sure whatever you think is like not that cold is probably absolutely freezing to me.
Well, no, I mean I'm from Miami, Florida. It's really hot. I guess maybe similar to where you live.
Yeah.
How hot is it there right now? What's the temperature?
Where's my phone? I gotta look it up, and then I gotta do the conversion.
Oh, it's all right. You can tell me in Celsius. I'll have a decent idea. Not exactly.
It's 33, which I think from memory is around 85, 87, something like that.
Yeah,
I don't know.
Oh wow.
I think it was only 30 the other day when we were speaking.
Oh, yeah. We should be better with the conversions.
Oh, there you go. It's 91.
Oh, 91. Oh wow. Yeah.
That's hot.
Yeah, that's hot.
All I know is outside it's hot, inside is aircon. So
yeah. Welcome to the show, Brock. We're so happy to have our first international guest on the show.
all the way from Southern Hemisphere.
Yeah.
Yeah, where it's summer there in Australia, correct?
It is rather warm outside at the moment, which is funny watching you guys sit there in jumpers and
Sweatshirts.
freezing.
About to put my hood up soon.
Oh, you know what? I learned that people call sweatshirts jumpers, right? Is that what you just called it?
I'd probably call that a hoodie, but I wouldn't call it. We don't call it a sweatshirt.
Yeah.
You say jumper?
Well, a sweatshirt to me, like you'd put that on, you wouldn't be sweating. You'd put it on to keep warm. A sweatshirt would be. I'm not sure what you would put on for a sweatshirt.
Yeah.
Pretty much any shirt in summer, I guess.
Yeah, it doesn't make sense. I say sweater or hoodie, but I know. Do they say jumper in England as well?
I don't know.
I'm not sure. They've got a few. They got like cardigans and turtlenecks and all sorts of strange apparel. But yeah, like I'd call it a hoodie or a jumper.
Fancy scarves. And...
I just say un suéter in Spanish. Just un suéter.
Yeah, I couldn't say that. Couldn't even say that abroad.
They're an imaginative bunch when it comes to naming things. It's basically just sweater, but with a fun accent.
With a fun accent on it.
Yeah. A few bold letters.
Yeah. Well, we're so happy to have you, and I'm also happy to be on your podcast as well. So for those of you that don't know you, can you just talk about who you are, what you're about, what you're doing? Just share with us your story.
So broad. So my name's Brock Cook. I'm an occupational therapist, and I, if you can't tell by the accent, live in Australia. I worked predominantly, or most of my career, in pretty much all aspects of mental health. I've done a bit of everything within mental health, and I am now lecturing. So I'm now working at a university teaching, just as a bit of a change of pace and new adventure, I guess. Like you said, I also have an occupational therapy podcast called Occupied, which is a bit of a creative project. I've been involved in a lot of OT related, I guess, things. A lot of online networks I've helped set up. I run a mental health network on Facebook called MH for OT, which I think has got about 9,000 OTs in it or something now.
Wow, nice.
I've a strong interest areas for me is obviously mental health, as well as things like occupation-based practice, a lot of technology. I've got some interest in things like neuroplasticity and how that might be able to be utilized in mental health care for OTs.
Mm-hmm.
And pretty much, in technology. I'm a bit of a nerd at heart, I think. So.
And you're a tremendous power lifter.
And I pick things up as a hobby on the sides sometimes, and I put them down. hopefully when they're meant to be put down, and not like.
Do you do competitions or?
I do. Yes.
Nice.
Yeah. It's a bit of fun. It's a sport I kind of just. I don't know. I was going to the gym and just doing normal gym stuff, and then just met some powerlifters and went, oh, this seems much more interesting than just, going in and broing out.
Yeah. Doing
bicep curls and stuff all the time. So, yeah, I've been doing that for 4 years now, 3 years, something like that.
Right.
And I'm a nationally accredited coach now as well. So, it keeps me busy.
Cool. I love that. I love that you have this occupation that you enjoy, and just talking about like everything that you just said about your background, like with mental health, and in the States, mental health for OTs it's been on the decline, or it has been declined. As long as I have known about the profession, have been in the profession, it's something that I always learned in school. Okay, mental health, in the States isn't as, I guess, isn't as relevant because it goes
not as common.
It's not as common.
Yeah.
It used to be, really. Well, what do you know, Mike?
Well, no, I mean, I've worked with a lot of OTs before. I mean, when you hear about OT in the States, you rarely hear about them working in mental health.
And I just we learned about it in school. We had a whole semester about it, and I'm just so curious, from your perspective and being in Australia, like how is that, how is mental health in Australia? Is it totally, is it just more common, or is it something that is still harder to get into, or like how did you get into that specifically?
Obviously I've got only got like conversations with people from overseas to compare it with, because I haven't worked overseas. But it is, for OT, it is quite common in Australia. There's, I think, 5 professions that are registered under our Mental Health Act, and OT is one of them. And that includes, psychiatrists, psychologists, social workers, etc. I think, and nurses, and then us. So like it's registered kind of in policy that OTs work there. On terms of occupational therapy itself, I think it's a perfect fit for mental health. I've always found it strange that it's not bigger in America, because even when you look at the history of OT, like that's where we started.
Right. Yeah.
In a lot of cases, like OT was kind of born in mental health, working in a lot of the big asylums and that kind of thing. And through now I'm going to go mind blank then. What was it? I can't remember the name of the movement. Essentially, like the getting rid of the big asylums and moving people back out into the community. Like that was.
I know what you're talking about, but I'm blanking
the something
out too.
care movement, and I've gone blank. But oh well.
Sorry.
I would think so. In my town, just looking at like percentages, in my town there might be 200 to 250 OTs, and I reckon there'd be at least 100 in mental health.
Wow, great.
Like it's quite prominent.
Do you,
yeah. Oh, sorry. Yeah.
No. Sorry. Do you work in like an outpatient facility or in a hospital, or what? Like, where do you work?
OTs will work anywhere. So like I've worked in acute units, like in acute mental health units. There are OTs that'll work for a mental health team, but in the general hospital, sort of servicing people that, you know, might come in for surgeries or injuries or whatever else, but still have mental health needs that need looking after. I've worked in community case management, community rehab, inpatient rehab, outpatient rehab, all within mental health. So yeah, there's a whole mental health sort of structure around the health service.
Mm-hmm. Yeah. I totally agree. Like, you know, that's where we got our roots. That's where we started. And 1917, and that's drilled into every OT's mind. What
was that?
1917 is when OT became a profession officially. And yeah,
in America.
In America. States, yeah. Oh yeah. So when did it become a profession in Australia?
Oh, don't ask me hard questions.
Oh, sorry. That was just random. We're not quizzing you.
Hold on. That's why we have the internet.
Later than that.
Yeah, I know we just celebrated
around World War II, maybe.
Yeah. I know because we had our 100 years last year. But 19
No, that's when Australia was founded.
Oh, Australia was founded January 1st, 1901.
Yeah.
By the way, it's definitely on our bucket list.
Yeah, our country is almost as old as the profession is in yours.
Yeah. Yeah. Yeah, I know with OT, and I just recently my last semester of teaching, I was a part of human interactions, and we taught about just the history of OTs in groups. And a lot of that had to do with mental health and just like the different phases of mental health in the different eras or the different decades in the 1900s. So it's like, you know, we had this presence in mental health, and I'm happy to hear that in Australia there's like, it's quite common, and that there's an array of settings that OTs can work in mental health. So like, I just want to know, have you done groups, or has it been more individual?
I've done both.
Right.
I've got fairly strong opinions on both. So in mental health, I think a lot of people, a lot of OTs, a lot of therapists will do groups because they've always been done. Mm-hmm. And my concern and the reason I stopped doing groups in a lot of those instances is there's a lot of evidence coming out now that say, especially in things like acute mental health, that groups aren't the most effective way of doing it. Mm-hmm. OTs in mental health will do a lot of psychoeducation, so a lot of education around diagnosis, or not necessarily the diagnosis, but the impact on their lives, on people's lives from, you know, with their experiences. But doing that, like that, to me, it's very individualized, same as everyone's experience of a mental illness is going to be very individualized. I can have 15 people with schizophrenia, mm-hmm. And they'll all be different. They'll all present differently. It'll all impact their lives differently. Some will be completely debilitated by it. Some it'll barely worry and it'll be a minor inconvenience. Mm-hmm. But on paper, it's the same diagnosis. That's one of the reasons why, and it's semi-controversial opinion, I guess. I can completely do my job without ever knowing what the diagnosis is, because I don't work with the diagnosis. I work with people, and I work with the impact it has on people's lives. Yeah. So, if I don't know what the diagnosis is, but I know that, they're struggling to engage in this occupation, then I work with that.
Yeah.
So groups don't, just because of the individualized nature of how, like, it's a slightly different, I feel, and granted I've never worked in a physical context, but it's slightly different in that if someone's broken their leg, it's fairly universal what they're not going to be able to do.
Right.
Like, you might struggle to walk, or if you end up with a cast compared to a boot, there's different things that you just know people are going to be either able to do or not do. Whereas mental health, I just feel is a little bit more contextual with regards to how it presents. So groups, the other argument against groups is if you've ever tried to put a whole heap of people and teach them all about anxiety management into a group, even just saying it out loud seems stupid. You're going to get a whole heap of people with anxiety and put them in a room and teach them how to manage their anxiety. When, again, everyone's going to present differently. My anxiety is going to be different to their anxiety. It's going to be different to her anxiety. It's going to be different to his anxiety. And it's going to impact people differently based on, what they do and what they want to do and what they need to do and where they work and all those sort of things. So some groups, diversional type groups in an acute unit, do have some merit. I don't think you need an OT degree to do that. Anyone can run that. When I worked on an acute unit, I used to have a rehab assistant who worked with me, and she used to run a lot of the diversional groups. And then it freed me up to do one-on-one and work with people more intensely.
Wow. Yeah, that's okay, that's so interesting, and thanks for sharing your opinion, because I know you have worked in, this is coming from your experience, so, nothing can be right or wrong. It's just your experience and how you see what benefits patients and what, what you take from that. Every person presents differently, and from your experience, you see that there is a need more so for that individual therapy versus a group where it may not be beneficial or even smart to conduct, because you're not giving everyone maybe the full attention that they need, or it may be triggering, or just from your experience. That's so interesting. And what I wanted to say was that I remember actually the first time, my first patient ever out of school, it was a baby. I think she was 12, 15 months, around there. And she had this diagnosis I had never heard about in school. And this was my very first patient on the job. And I remember my friend told me, she's like, oh, great. Of course, you learn about all these diagnoses in school, and then you get this one diagnosis you've never heard of. It was some genetic disorder. And she said, don't treat the diagnoses, treat the symptoms and treat the person. And then for my first patient, that was amazing, because I realized despite the diagnoses, despite the condition, I've worked with autism for many years. So every kid is different. And I don't think about the autism. I just think about the kid and their specific needs, their specific deficits, and their strengths. And I love that you said that, because, yeah, you see someone with a broken leg, they have a broken leg, but when two people are presented to you with anxiety or schizophrenia, it looks totally different.
And I think, even the broken leg is a very generalized example, but obviously there's going to be some differences based on whether, one's a sprinter and one's a, office worker kind of thing. There's going to be some different things, but diagnosis, presentation, you kind of know what you're getting with that kind of injury.
Mm-hmm. Yeah, of course. I don't want to generalize physical injuries, but yeah, I was trying to get at, with the mental conditions, it's not so black and white, like it might be. And so your experience around that is really interesting, So did you want to say something?
Yeah,
Mike?
well, I just wanted to ask, is there a specific diagnosis you see a lot more of, or is it more of a mix?
What would you see? It's probably a mix. Like the main ones you'll see, say in an acute unit, would be schizophrenia, bipolar, depression, like the main sort of bigger ones. Once you're in there, there's all like subcategories of those different diagnoses as well that, that's the doctor's job to work that out. But sort of in the community, depending on where you're working as well, like if you're working for the public system, the public health system, in the community, you'll still see those same people. So those, people with those same diagnoses, but they're going to present very differently when they're not acutely unwell. So the interventions that you do with them are going to be different as well. If you're working in the private system, again, a slight generalization, but generally in the private system, you're going to see probably more of the depression and some of the more specialized things. So you might see some more of the anxiety, more of the OCD, those kinds of things. There tends to be, and I don't know why, but there just tends to be more psychologists in the private sector. So a lot of those conditions that maybe require more psychology than anything else, they'll see more in the private sector. I wouldn't think you'd see as much sort of psychosis. You'll obviously still see some, but you wouldn't see as much psychosis, paranoid schizophrenia, that kind of stuff in the private system usually. Yeah. So, okay. So, I'm thinking about an interesting question. I remember just being in that class as an adjunct professor. The professor I taught alongside with, she would always say, how are you going to distinguish yourself as an OT in mental health? Because that group was primarily, that class, human interactions, was primarily around mental health and groups. But even though it was heavily group based, it was still the idea of like, how are you going to distinguish what you do from a psychologist, from a social worker, and mental health? And she was always, drilling that into the students. And I think that's so important, because if we're not careful, we can look like a PT, we can look like a psychologist, so like what are you doing maybe specifically, or like things that you've seen where it's like that differentiates OT in mental health versus psychologists, for example? Yeah. So my answer to this, and this is my wheelhouse, this area is what differentiates OT, is the same in mental health as it is in every other field, in that what differentiates us is the use of occupation. So in particular, it's use of occupation as the therapy and not just as the outcome. So say, for example, a psychologist will use a psychotherapy with the outcome being, getting them back to health kind of thing. We'll use actually engaging them in the occupations they need to do to get them back to health. The psychiatrists over there, your psychologists are a bit different too. So your psychologists prescribe meds, ours don't. That's purely a psychiatrist over here, deals with the meds.
I think that in here, psychiatrists prescribe meds and nurse practitioners, but not psychologists.
One of them prescribes meds and one of them does not, and I'm not sure which one it is.
The psychiatrists, I don't think psychologists here prescribe medications.
Okay, they used to. Maybe that's different.
Yeah. We'll have to double check.
It might be the other way
around. No, psychiatrists. Right. Okay. So sorry, keep going.
Okay, so here, psychiatrists are kind of like mental health GPs. And there's a lot of psychiatrists that are going to get annoyed at me for saying that, but they essentially deal with the medication and the general health stuff for mental health patients. So they're the ones that deal with medication. So they'll, be trying to get the person's on the right medication and the right dose to get them back doing what they need to do. So it's essentially the modalities that we use that differentiate the different professions, because obviously we all want people to, get home and get well and stay well. A lot of social workers do the social side of it as well. A lot of our stuff is about using that. So if you're working in the community, it's about linking them in and with community engagement, linking them in with services, so that they're able to essentially support themselves. We want them to be able to look after themselves. And, say if me or you wanted to I don't know, join a club, we'd go down and join a club. Whereas someone with, high anxiety or paranoid schizophrenia sometimes might miss that link on, well, okay, this is what I want to do, but how do I get there?
Yeah.
So that's sort of where the OT would fit in, whereas a psychologist, that's not the kind of thing a psychologist would look at. They're more looking at thought patterns and cognitive processes and that kind of thing. Whereas we very much look at that person's engagement in their activities, but we actually want to do that with them as the therapy.
Yeah. Just like you said, like that's whatever whatever population we're working with, whoever we're working with, like that's always our end goal. So I love that you said that. It's something that I think people forget about, or maybe like old school OTs, or just like just being like going through school here, and I'm sure it's very similar where you are, where it's like drilling in occupation, client-centered, evidence-based, all that stuff. But like sometimes, you see OTs that just were a little bit more old school, that are a little more biomechanical, that the occupation is completely lost. And it's like sometimes I'll see an OT and I'm like, I'm not sure if that's a PT or not, or specifically in like a rehab setting.
Yeah, a lot of OTs get pigeonholed into physical rehab, and that's, I think, a vast majority in the States. It's like we do this weird thing where in some rehab centers we'll split body parts between PTs and OTs. It's like PTs will do like
lower body,
waist and below, and OTs will do like waist and above. It's like that's how they kind of divide the labor there, which is just so silly because that's not how we were. That's not like the school we went through. We didn't go through school being like, all right, you're only going to treat upper body now for the rest of your career. So it's like, it's just this weird division of labor that we've done here. And it's like OTs has gotten away from a lot of other cool things that they could do.
Mm-hmm.
Yeah. And I think I think when OTs end up doing that, they very much neglect some really valuable stuff that the profession can offer. Like, my brother's a physiotherapist as well, so we've had this discussion. And I still remember him coming to me while he was still at uni. He's younger than me, and saying like, "Why do physios do the whole body except hands?"
Oh,
yeah, that's
and
interesting.
I'm like,
that you guys say that too. Yeah,
I have no idea. I can't answer that. I am not the largest fan of OTs being involved in hands, but it seems to be an area that somewhere along the historical lines OTs have latched onto, and we've held onto it. But from a fundamental point of view, I think it's probably better suited to physio. And OT needs to. I think OT's fallen into a trap over time of trying to justify anything with an occupational means, so like an occupational outcome, instead of sticking true to what we, how we developed and what we actually are, and using the occupation as the therapy as well. So we'll do anything, like, we'll do hands, we'll prescribe splints, and we'll prescribe equipment, and just that, as opposed to adapting equipment to help a person actually engage in something that they want to do, but their injury at the moment is preventing them from doing. I think, and it's slowly changing. I don't know if it's changing over there. I'm not sure, but in Australia, I know it is slowly changing back to being very occupation focused, which is good. But then again, like we never really lost like the mental health aspect as well. Right. Whereas you guys, it seems to have like really slipped. I don't know. I'm not sure. I've heard from other people over there that it was more of a policy thing, why it happened. I'm not sure. But I know like Tina Champagne. I don't know if you know Tina, she does a lot of sensory mod stuff. She's a mental health OT.
Oh, yes, I know her. Yes.
Yeah. Like I've spoken to her, and I think she was the one that told me that it was very much a policy thing, but she still works in mental health, but again, it's fully private, so she can kind of do what she wants. It's not trying to fit into a health system kind of thing.
Yeah, I know. I love her work. She does, I've been to her website, and she has sensory processing a lot of information, but for adults, like adults that have sensory processing stuff. Do you in your mental health, do you come across adults that have sensory processing disorder or anything like that?
Yeah, yes and no. I wouldn't say it's a formalized sensory processing disorder. In my opinion of it is that everyone has, it's kind of like autism in that everyone has those traits in some form. I think everyone processes sensory information differently. Some will process different senses better than others, or be able to modulate different senses better than others. So I don't tend to look at it in mental health. I don't tend to look at it as a formal sort of disorder. I look at everyone. I'll look at everyone's sensory stuff if it looks like there's some sort of sensory issue. But I'm looking more specifically for what sense. Is it a high or low threshold? How are they reacting when they go over or under that threshold, etc., rather than looking at it as a complete sort of separate diagnosis kind of thing.
Yeah.
Like even I know how I process things. I know that I need a lot more auditory input than some people. I know that I get very easily distracted in high visual input areas. So like if me and my wife are out to dinner and it's a busy restaurant, I will just be like staring around the room kind of thing. I get distracted and then she kicks me under the table. But like I'm aware of that. Like I know how I process things and I know that that's different from the norm. So I guess technically I would have a sensory processing disorder if it was going to be like that as well.
Yeah. I know there's, special criteria but that's right. We all process sensory differently. And, for myself, since I feel like, and maybe you can talk about this if you've seen this, but because I come from a lot of anxiety, I get overstimulated easily, auditory and visually, like yourself. But I found that, of course, deep proprioceptive input is very relieving. A big hug. Like doing weights.
You should try powerlifting.
Oh yeah.
That's true.
Yeah. Like
Maybe that's what I need as well. See, there you go.
Yeah, you get your deep proprioceptive input.
It's just the heaviest weighted blanket in the world.
Yeah.
Basically, yeah.
Yeah, I mean, I like to do handstands, and I feel like just a lot of, and push-ups and more static things. But yeah, I should try powerlifting. Yeah. But oh my god, I lost my question.
I hate touching my food.
Oh, he has a lot of tactile.
Like if I'm eating a burger, right, and the burger like starts to drip out of the back like onto my hands, it like makes me want to like immediately go wash my hands. Yeah.
You have a lot of tactile stuff. But anyway, yeah, I think that I like what you said, because we notice as OTs, I think that's really special to us, is that we notice how people modulate sensory information, how they process it, how it impacts their performance. So have you noticed that? Have you used, maybe directly or indirectly, some sort of perhaps like those calming sensory activities for, let's say, people that have anxiety, or maybe in other diagnoses that you feel like you've integrated some of that, maybe like sensory based activities?
Yeah, no, definitely. I've done it a fair, and I try to use it fairly informally, rather than come out with a checklist and try and work out how people are processing things. Mm-hmm. But especially when I've been doing sort of interventions with people, like if they're known, or if they know that there's sort of anxiety at play, then that's easy. Like you can work directly with that around, what situations and what triggers, etc. But I'll use some form of sensory mod with most people that I actually do any kind of assessment with. And the main reason I've found for that is that anxiety is one of the only things that can acutely change your cognitive level. Mm-hmm. Other than that, generally your cognitive level up or down is fairly permanent. But anxiety is one of those few things that can change it acutely. So if I'm able to run some sort of relaxation, run some sort of sensory mod with someone before I do an assessment with them, mm-hmm. or before I interview them, or before we go out somewhere, or that kind of thing, I found I got much better engagement. I got much better results because their cognitive level was sort of much closer to normal, or their norm sort of thing. And it's the same thing. Like, I know a lot of people are looking at it separately, but I look at things like mindfulness and meditation and stuff as a sensory mod as well.
Yeah.
And even in my own personal experience, like I use that quite regularly, especially, there's really busy times at work and stress is high and I'm prepping for a comp and everything just seems to like too much. I'll really try and build that into my routine, at least for that period. And it really helps. And I've used this is a slight sidetrack, but I've used that sort of thing and this skill set with my athletes as well that I'm coaching. Like I've prescribed meditation and that sort of stuff with athletes who, might freak out a bit when it comes time to actually, you've been doing this in training for so long, doing it on the platform in a competition slightly different. So trying to build that into their routine before they get to their competition, like I've used it for that. And I'll use it the same thing with people, they might have been in hospital for 6 months and it's time to start re-engaging in the community. There's a lot of anxiety around that sort of transition period. So trying to do some of that sensory mod before you go and actually having something small and inconspicuous that they might be able to do while you're out, whether it's, if they're tactile, it might be like a fidget or something. But if it's, it might be a meditation, it might be music. A lot of the time, music I've found is one of the more powerful sensory mod tools. So, like, even just having, like, when I worked on the acute unit, I used to have Spotify on my phone so that the person, whoever I was working with, could choose whatever music they wanted. Like, it's got nothing to do with me in reality. So it's whatever calms them or alerts them is what we need. So I'm like, streaming services have been the best thing ever for sensory mod because you no longer have to, oh, look, here's my big box of CDs. Let's see if we can find something that, suits you kind of thing. Yeah. It's like, what do you want to listen to? Let's find it. Yeah. Yeah. So, but yeah, doing that sort of stuff before you engage in, a session or a trip or whatever you're doing, I found really helps. I've done the training for weighted blankets and that kind of stuff because they have been researched for use in mental health, especially around seclusion and restraint reduction. But I've never actually used it with anyone. I've never found anyone that required it really.
Yeah.
So.
That's interesting. Like it's like those using the sensory input and the sensory activities, it's like preparation, so to speak, so that a person can be modulated and ready to engage in the actual session or the actual activity or occupation. So I love how these principles that we learn in school, that in the US we typically don't apply to mental health, that, if someone wants to make the jump or transition to mental health, it's really like we have to just get back to, remembering it's not, even though we may not have that much experience with it here, like just remembering it's the same process. We have the same goal, and
should be the same thought pattern.
Yeah, exactly. That's so cool. I'm really I'm motivated to or do something to get it back here in the U.S. as much as it used to be. And I do know a few, actually know one OT that has her own practice in Florida, and she does mental health, and I just like a private practice too. So I just think that's cool. I think when people think mental health, the first thing they think of is psychologist or psychiatrist. So it's like, how do we get people to see that, it's, the thought, the thought patterns, all those things are important, but how do we get people to see that it's, the occupations that it could, working with an occupational therapist, like how that can really benefit them?
The $1 million question.
I know.
And in that regard, it's probably the same here, because even though there are a lot more of us working in mental health, to the general public, general public doesn't really know what OT is anyway, but everyone I used to tell when I was like, I work in mental health, I'm an OT kind of thing, used to be like even if they knew what an OT was, be like, what does an OT do in mental health?
Right, yeah.
Because their previous experience would have been their grandma was in hospital and the OT came and helped them with a wheelchair or a walker or something, or something to that effect. When dad had a stroke, there was an OT in the rehab ward or something like that. Right. And they're like, well, how does that correlate with mental health? I'm like, well, that modality itself doesn't, but like you said, the thought pattern between different practice areas for an OT should be the same. Like, I should be able to walk onto a rehab ward, and granted, I'm not going to know the specific sort of probably the processes of that workplace, but like the specifics around like what's available. But I know that my job is to try and get these people somehow, I'm not going to know how, but somehow to get them back to doing what they need to do. Because that should be the same for any, and same with pediatrics. Yeah. Like, yes, the occupation is different because most kids, their main occupation is play. Right. Or annoying their parents. Yeah. But the goal is the same. Like, you aiming to get these kids back to doing what they need to do, which might be engaging at school. It might be, helping out at home. Like, it might be whatever it is for depending on the age kind of thing. For little kids, like little babies and stuff, it's their main thing is like you need to be getting them to be hitting those milestones. Yes. So you're engaging them in occupations to be able to hit those developmental milestones. And, they're usually the things that you're doing with kids are things that most kids that might develop and hit those milestones normally would do normally. Yeah. It's not, I've always said, and people always argue with me, but I'm like, OT is the most common sense profession you'll ever find.
Yes, it is.
Because it's like, you need to do this, let's do it. Yep. Like, that's it. There's no special magic formula.
That should be OTA's new slogan.
Oh, they'll sack me if I say that. Well, not that I work for OTA, but they'll get angry at me at least. But I think OTs have an issue with thinking of it like that because they're like, no, I trained really hard to get here. I'm like, yes, you did, and I'm not trying to devalue what the profession does, because what we do is actually take that common sense for us, and we help people who can't quite make those links to be able to follow the process that any normal person would do. Mm-hmm. So in mental health, like I might work with someone who needs to be able to say, I don't know, they might need to be able to learn how to manage their house. So what's involved in that? They need to be able to cook, clean, do their washing, etc., all those sorts of things. Now, a normal person, not say normal person, that's a bit derogatory, but I'd say a person without a mental illness, say me going into when I first moved out of home, most of those sort of processes I could roughly work out myself. Someone who has, say, had schizophrenia since they were 16, they're just starting to move out of home. One of the things with schizophrenia is quite often people sort of mentally will be almost stunted at the age that they got it. So I've worked with people who've been like 24, had schizophrenia since they're 16, but you talk to this dude and it's like talking to a 16-year-old kid. Wow. He just wants to go down the beach and perv on chicks and, wants the latest iPhone and all those sorts of, things that 16-year-olds might do. Yeah. So working with him to get to a point where a 24-year-old would be in sort of living on their own, I'm there supporting him to go through those milestones and learn those things that, most people probably would have learnt between 16 and 24. Yeah. But he's not able to make that link between that sort of this is where you are, this is where you were, and this is where you need to be kind of thing. And that's where the OT comes in. But it's specifically with around engaging in those things that he needs to do, like maintaining his house. Otherwise, he's going to get kicked out and be homeless kind of thing.
Yeah, yeah.
You know what? I'm wondering, hearing you talk about that, it's like that just makes so much sense, like those approaches. And I'm not sure if psychology in this country even does those kinds of things to help people with mental illness.
I think it depends. I think there's depends on the setting. Typically here, social workers will help you get from A to B in terms of like, okay, you're being discharged, you need to go here. But in terms of that long-term ongoing support, that I think OTs fill that role in supporting people in living their occupations. And every day, everything we do is an occupation. It's not just getting a job, but people listening to this should know that. But yeah, so that's where we come in, you know.
It just seems like something that's just so important. And I don't know, that the fact that as a healthcare provider, there's nothing that jumps out to me in my mind where like, oh, if you have these problems, you should go to this provider. It's like, is kind of sad in a way. Right?
It does make me wonder, because obviously if it OTs, because to me, like in Australia, that's where OT fits in mental health.
Right.
If it's, and I know OT is not really big at all in mental health over there, so it makes me wonder, one, if that particular service is being delivered at all, or two, if it's being delivered by another profession,
I
it
think
really
so.
should be delivered by an OT.
Yeah.
Because generally here, like psychologists work with the mind, so I work with disordered thought patterns, and changing how people sort of view situations and that kind of stuff with CBT and ACT and all those different sort of psychotherapies. It's very much a talking therapy in a lot of cases, as opposed to OT, which is very much a doing therapy.
Yeah.
But it might be.
Right.
Psychology might be sort of picking up that slack, I guess. I don't know. Someone might be. I couldn't see it being a super effective healthcare system if that sort of need wasn't being done by someone, surely.
It's because we don't have a really effective healthcare system. To be honest.
Where do we begin?
We have a lot of things going back and forth between people these days in the U.S. and healthcare is at the forefront of it, really.
Yeah, healthcare is hot. And sorry, go.
I was going to say that may be the difference too, because you guys are like almost a fully private health service, whereas
exactly. Except if you're over 65, then you get Medicare, but under 65, it's all private.
Yeah, see, we get that the whole
time. Yeah.
The whole lifespan kind of thing. So there's like a lot of the services, like the services I've worked in, have all been government health service. So it's all been public health,
right? Which
is all essentially free to the people that we work with.
Yeah.
There's some things. So mental health care through the public system is all free. There's a lot of the medications are subsidized, so there'll still be a small payment for some people for some of their medications. For some services, and generally it's more of your able-bodied services, like just going to see your GP and that kind of thing, the government will subsidize them. They're not completely free. There are a few sort of GP services around that will fully, like it would be free. They call it bulk billing. So they'll be free to people to go and see them, but generally those are so busy that it's hard to get in sometimes. And then there's others where you just pay the difference kind of thing. So the government might subsidize, say $70. I don't know what the actual numbers are, but say $70 of the visit, and the visit costs $90. So the person will pay $20.
Okay. Yeah.
I know you're interested, Mike.
Yeah, no, I really wanted to ask you about that because it's a huge conversation in this country. In fact, one of the candidates, that was coming up about 2 years ago for president, he made a really big push into universal healthcare and got a lot of traction, a lot of people behind it and stuff. And it's like, is that the next step for United States healthcare system? And it's like, having someone like you on the show is awesome because, we've never, I don't think I've ever spoken to someone in my life, let alone on the podcast, that's worked in that kind of system. Is there any kind of like difficulties or like bureaucracy or like things that are kind of issues with it? Or, I mean, I'm sure there are, but more so than,
you're working for the government. There is a lot of bureaucracy.
Right.
There is, I don't think it would be any more than, say, working for a really big organization.
Right.
Mm-hmm.
There's obviously the health specific things, like there's scope of practice issues and that kind of thing. And then there's sort of you got a lot of legislative health things, so especially in mental health, where we have a mental health act, where mental health act's the only act that people can be essentially just detained and treated against their will. So if someone is, and I don't know if you guys probably would have something similar, but I think you guys call it sectioning.
Mike,
something like that. Yeah.
I mean, I'm sure if they're a danger to themselves or others,
they get Baker acted,
institutionalized.
I think it's
yeah. So we have that ability, which is legislated, which you don't have in, say, private health over here. We can administer involuntary treatment for people who are essentially too unwell to realize that they need treatment, and might hurt themselves or do something silly and hurt someone else, that kind of thing. On terms of the profession, it probably works. It probably does work in the profession's favor, because then a lot of the positions, like I said, like OT is one of five or six professions that are actually registered in the Mental Health Act. So it works in that regard, because OT is a mental health profession legally on paper.
Right.
Yeah. And then it works with regard to workforce, because then sort of the profession itself is negotiating with the health service as a whole, as opposed to individuals trying to negotiate, you need an OT here, this kind of thing. Sure, yeah. So I think there are definitely benefits for the various professions with regards to working in a public health system. I think the main benefits are going to be to the consumers. Yeah. Obviously. And I think it's not so much. I think people who are earning good wage and that kind of stuff, it's not so much probably going to change much at all for them. So we have a private health service as well. We have private insurers. Right. Like I've got private health insurance. You get a tax break when it comes to doing your tax if you've had private health insurance for the full year. So
you get
essentially trying to encourage.
Yeah.
Yeah, essentially trying to encourage people that if you can afford it, don't burden the public health system. Like there's another health system there that you can use, kind of thing.
Super interesting.
It will very much help sort of your low to middle income earners more than anyone else. The people that might be avoiding health services because they can't afford it, or they don't know if they can afford it, or that kind of thing. Yeah. So I think overall your health outcomes would they would change. I think you would, it's one of those things where, you're going to fix something, but then something else is going to pop up. Yeah. It's kind of like the whole, we're living longer. So health outcomes up until the age of 70 now are much better, but now we're seeing all these other things that previously weren't an issue because we didn't live long enough to see them.
Yes.
I think you will fix a lot of your issue. Well, maybe not fix, but you'll change a lot of the health issues, especially around just basic health issues, injuries, disability, that kind of stuff, for middle to low income earners. But it might highlight some, other issues that might not fit. It depends how the system's designed as well and what they're going to fund.
Right. Yeah. I mean, that's actually really interesting that you mentioned that you can get private insurance if you want to, and then get a tax break for it. That sounds like such a common sense option for us right now, because it's like we already have Medicare for 65 and older. It's like just upping that to the population who necessarily can't afford private insurance, and then incentivize. That sounds like such a good option. I think what universal healthcare would do for us in this country is just make it so much more simple. Just the whole idea of health care in this country. There's so many times that, even myself and Erica, we'll go through our own health insurance policies and try to understand what exactly is covered, what's not covered, when is it covered, what kind of copays we're going to have.
Yeah, I've been so screwed.
Yeah, every year it changes. Every year it goes up in terms of cost, and it's a complete disaster right now. And it's like, just burn it all down and just do something that is more simple. It's like that's my opinion with it. But
and it'd be interesting to see. I think the issue for you guys, and it'd be mainly due to it being such a humongous country population wise, would be how do you roll that out?
Right.
view from the complete outsider, because obviously I'm not involved in that at all, but from a complete outsider, they'd almost be better off starting, rather than trying to redo the health system to start with, would be to start some kind of like their own insurance provider. I'll explain this in a second, because it's similar to another health model that we have. Would be to start their own insurance provider, but include everyone at no cost, kind of thing.
Right.
And then down the track, once that's sort of rolling and people, you now have this much money to utilize from the government for healthcare costs, whatever you need throughout the year, kind of thing. And I say that because it's just reminding me, we've just rolled out another health model, which is an actual insurance model for people with disability, called National Disability Insurance Scheme, in which it's meant to, rather than services being controlled by the government and being allocated to people with a disability are essentially going, well, this is how much money you're qualified for or eligible for. You get to choose whatever services you want to use it on. So if you want to buy a new wheelchair this year, sweet. If you want extra support services, sweet. It's completely up to you how you spend it. It's what you want to spend your money on, but this is your allocation. Rather than it being the other way around, it's kind of flipped the model on its head. And I think for you guys to roll out, say, universal healthcare on such a massive scale, it would almost have to be that kind of model, where there was a government insurance company kind of thing.
Yeah.
And then people could utilize that to, because all your hospitals are already, like, our hospitals are owned by the government. Your hospitals are all private.
Right.
So it would have to work something like that, because the government's not going to go around and buy all the hospitals. Just wouldn't happen.
We could easily do that, because we already do that with housing. I mean, housing loans. I don't know if you ever heard of like Fannie Mae and Freddie Mac and stuff. Those are those are big players in like the housing crisis, when the market bottomed out and everyone lost a lot of money. Those are government subsidized programs or companies essentially for housing loans, and it's like we could easily do that. I don't know. It comes down to what's stopping us from implementing like common sense policies. Is there too much money already in private health insurance, or is there, I don't know, it's things like that. But I actually looked this up before we talked, because I knew I wanted to ask about this or at least discuss it. It was like, what kind of tax does the average citizen in Australia pay versus what we pay for Medicare? It's like, I think you guys pay around 2% for Medicare. At least that's what Wikipedia said. This could be totally wrong, but
it's possible.
Yeah.
I know what I pay. I know what I pay out of my income. I don't know what percentage of that goes to Medicare.
Right. Yeah.
And it turns out in 2018 now we pay 1.5% of our income.
You say 2.9%?
Well, no, that was
sorry.
different. So like we pay 1.5% for Medicare that we don't get until we're 65. So how the heck does that make sense when you guys are paying 2% for healthcare for your whole lives, and we're paying 1.5% for healthcare that we will get over 65? That is only if it doesn't run out of money before we get to 65. So it's like,
see, the other thing is that that's not all of the funding.
Right.
So Medicare's federal. So Medicare's the federal universal healthcare kind of fund. Our health services are actually all state services. So I live in Queensland. I used to work for Queensland Health. So each of the states would get allocated some of that Medicare funding, but then would also have money that, like, the actual staff and everything were hired by the state. So there would be money from the state as well. So it might be more. It would be more than the 2 point whatever, but it still would be. It might be 4, say, for example.
Right.
Once you looked at sort of what the state takes and what the federal, what Medicare puts in, kind of thing.
Yeah, a lot of questions these days.
Yeah, I'm personally overwhelmed by all this talk, and
we're healthcare providers, though. That's what's sad. It's like we are the major people that should be understanding this stuff, and
that's part of me thinks that's what, policymakers want, is they don't want the general public to fully understand how the system works. And part of me thinks, well, maybe the system itself is just way too complex. Yeah. If, the people that work for the system aren't really sure how it works. And, what hope does everyone else have? Exactly. Kind of thing.
That's how I feel.
Well, we have an exclusive here. Oh. You heard it first. Our long-term goals are to lobby.
Yeah.
Yeah.
Yeah, actually, that's like a super long-term goal for us, is like, how can we try to affect change at the highest level based on, communities we've built around the idea of healthcare provider well-being. That's something that we're really interested in doing. Actually, that would bring me to my next question with you, actually, is like, I'm sure you guys talked about this when Erica was on your show, but what's your burnout story like, and how did you kind of climb your way out of that, if you used, your own skills as an OT in mental health or anything else?
I think I did eventually, but it took a while for me to get to that stage. So I'd been obviously working, and was in a job that was having, a few difficulties in that job, just wasn't coping, had some other stuff going on. I had like close relatives passing away and that kind of stuff. It was a fairly ordinary time in life. I didn't know what was going on at the time. I just assumed it was, just life being life and being difficult at the time. I knew my sleep had gone to shit. I knew I wasn't coping at work. I knew I was waking up in the morning and just not even wanting to go to work. I had absolutely no, like a profession that I was, am really, really passionate about. I just had no energy or interest to put into it. Mm-hmm. Like I said at the start, I've done a whole lot of different, projects and that sort of stuff for OT outside of work. That was one of the things that I also noticed, was I was pulling back from a lot of that stuff. And that was a conscious decision, because I'm like, I don't have the energy to even cope at work. Right. Like I need to pull back on a lot of those, I call them extracurriculars, pull back on a lot of those extracurricular projects so that I can sort of get my head back in the game and that kind of thing. But even that just didn't work, and I just found myself spinning, and I ended up quite depressed. Like I ended up with depression, and that was when I hit rock bottom. I still hadn't put two and two together around burnout. I hadn't even put two and two together around the depression. Yeah. And I worked in mental health, so that annoyed the hell out of me as well. I'm like, how did I not see this coming? I had once I clicked onto the depression eventually, and I had a really good friend and she wasn't a clinician at all. She was just a really good friend who'd been through similar, and she helped me sort of out of that hole, at least in the initial stages, until I could sort of think straight again. And I was still at that workplace for another 2 months after I'd sort of started coming out of the depression. And that was when I clicked onto the burnout, because I was starting to feel better with regards to the depression and my mood and that kind of stuff, but still had that, I hate going to work. My sleep was still screwed up. I had no passion for the job anymore. Mm-hmm. And there was issues at that job as well that, weren't going away. So it obviously, it wasn't the depression that was causing it, kind of thing. There was additional things. Yeah. I realized, and that's where I think I came to the conclusion. That's when I started looking at it like an OT, which was really hard. It was surprisingly hard to do that when it's yourself.
Yes.
Because the stuff that I did was stuff that I've done a million times with different people, but actually even seeing the situation in the same light when it's yourself and you're that close to it was almost impossible. And I only sort of realized that by bouncing information off other people so I could see how they were seeing me and what was going on. It was an interesting experience. I'll say that now. At the time, it didn't feel interesting.
Yeah.
But yeah, it's interesting in hindsight. But that was when I started looking at it. Well, think about it like an OT model. Like I can either change what I'm doing at work, I can either change the environment, so change jobs, or change how I think about it. And I'm like, I've already started changing what I think about it because I'm starting to come out of the depression and nothing's changed. There's nothing I can change at work because I was changing things based on what was going on and nothing was happening. So for me, the only sort of thing was I needed to change my environment. So, and it got to a point where I needed to do it immediately. So I ended up taking leave. I had long service and a whole heap of leave. So I ended up taking almost 7 months leave, all up.
7 months. Wow, man.
Yeah. Which was, that to me was a lifesaver, the fact that I had that leave there, because I don't know, like I was saying to Erica the other day, like it took me probably close to 5 months, I reckon, to fully come out of that funk.
Yeah.
Wow. So, sorry, I don't want to interrupt you, but that was actually another question. Is like I know you guys have a lot of paid leave. It's the same thing in Europe. That's another big problem that we have in this country is like how much paid leave workers get. So like when you say you took like all those months off, was that something that you accrued over time while working, or how did that work?
Yeah, so we get, and it'll be different in different workplaces, but generally you'll get say 4 weeks a year of annual leave.
Yeah.
But then after you've worked in the same place for 10 years, you get what they call long service leave, which is kind of like bonus. Wow. So you'll get, after 10 years, you get 13 weeks. And then I took that at half pay. So it doubled the length pretty much.
Wow. That sounds awesome.
Yeah. It would have been nice to take it under better circumstances.
Oh, yeah. Sorry.
But the concept itself is good. Yeah.
Yes.
But but it was good, even under those circumstances. It was good because I knew I had it there and I needed it, so I used it. So I ended up taking, and I had full support of my partner. She obviously could see how miserable I was and just thought I needed to get out of that place because I just wasn't happy in any part of my life because of, what had been going on. So I took that time off, and for the first, I reckon 6 weeks, I just chilled. I did nothing. I relaxed, tried every coffee shop in town, and just tried to not think about what had happened. And then after that, I picked up some casual work, just doing tutoring at the university. So like teaching a couple classes a week, nothing much at all. So I was just sort of enough to keep me busy, but not to sort of overload. And I did that so I started my leave at the start of December 2016, and I was on leave until last June, say about 7 months all up. And then while I was on leave, I got the full-time job at the university. So I never went back to that workplace, which I wasn't planning on going back anyway. But the university just changed, a new environment, a much more flexible environment, a lot more autonomy. It's the complete opposite of where I was pretty much. And yeah, I haven't looked back, but it's the burnout aspect of it. I never really sort of realized until sort of like in hindsight.
Yeah.
It was very difficult to sort of pinpoint that. And again, I didn't have anyone that was able to, point it out to me who knew about burnout or that kind of thing. So I didn't know what I was sort of going through until afterwards when I started, hearing about it and reading about it, going, oh shit, that was me.
Yeah. Yeah, I like you and I have that very, very similar experience where I didn't know. You're so right. Like when you're going through it and you don't like learn about, hey, this could happen to you, you know, you don't learn about burnout can happen to you. And then, so when you're going through it and it's so slow, you know, and like we talked so much about this on your podcast. But it's like,
Did talk a lot.
Yeah, we talked a lot about it. So if you're listening now, then if you want to hear like that full interview and that full story, check out Brock's podcast, Occupied.
We'll put it in the show notes.
Yeah, we'll talk more about where people can find him and all that stuff. But like, yeah, you know, just like that's such a testament to, okay, we learn the clinical skills. How are we going to be supported in our journeys when these things happen to us, but we're not taught about it, or we're not, you know, even prepared for it, and then it happens. And you and I have very similar outcomes. Like it took us a long time to piece everything together, to look at it and understand like, okay, there's different factors. And I like how you said, okay, I had 3 choices, you know, change myself, change the environment, or I forgot your last one, but it was those, yeah. So it's like, okay, so like you have choices, and I think a lot of people just assume, okay, you're burnt out, something's wrong with you, you need to suck it up. But as you and I, you know, we know better, and it's much, much more than that. It's the work environment, it's the policies, it's the personal factors. And I think for each person that goes through burnout, it could be more personal factors, or it could be more work environment, or it could be like, it's just like the recipe. The ingredients are the same, but the recipe might be different for everyone.
Yeah, and that's it. Like, I think that was probably one of the issues, and this, I can tie this into what we were talking about before. That may be one of the issues with it being a government department was there's no scope for me to be able to change. Like, it's not like I can change the hours. I had to work the shifts that we had to work because it was shift work where I was. Like, it was very, you know, bureaucracy. It was very set in stone. It was very, this is how it has to happen, and
right.
You know, all that's fine. Like, it's, you know, based on evidence and whatever, how it's set up, that's fine. It just didn't work for me at that point in time in my life. Whereas the workplace I'm in now, it is very flexible, and it's very much more based on the KPIs of you just getting your work done, essentially. So like if I need to leave early, I come in early, like, and I set my own sort of time. As long as I'm at class and teaching my classes and that kind of thing, then it's a lot more flexible. It's a really good team. Great boss. Hope she's listening. But yeah, maybe that is something that's different. And like, I've never worked in private practice, but I think in private practice, maybe you would have a little bit more flexibility. So you would be able to impact the environment a bit more, and maybe you would be able to stay, like if you were going through burnout. But just where I wasn't able to do it. So the only thing that I had control over was me, and I had to take myself out of that environment to make that change.
Yeah.
I think the minds of every United States citizen exploded on this podcast when you talked about how much leave you were able to get.
Well, you know, my friend Izzy, so one of my best friends, Izzy, shout out to Izzy. She's Canadian. She's a physiotherapist, and she gets like a whole year off for maternity leave.
Yeah, that's
so
mind-blowing too.
Yeah, it's kind of
so much more than we get.
Kind of ridiculous.
We do get. I don't know. I speak out of turn. I don't know exactly. I know mothers can take up to a year off for maternity leave, but I don't think it's all paid leave. I'm not 100% sure.
Our country is the only in the entire world, that doesn't have a federally mandated paid leave policy for new mothers. And every time a new mother requests off, the story you always hear is them scared about losing their job and how long that they can comfortably take off before their boss starts asking questions, stuff like that. Yeah. Brutal.
Well, yeah, there's interesting things about every country, every government.
It's just me venting.
We're just venting. Yeah, this is just us thinking out loud about everything. Mike, do you have any other questions for Brock?
I think I'm good for now.
I want to ask. Well, okay, so I want to ask you, Brock. You said teaching, And I taught too. So what's your favorite thing about that?
About the teaching itself?
Yeah, or about like your specific role.
I think like I'm definitely enjoying the autonomy of it, but for the teaching itself, I don't know, I like being able to use my experience, either, clinical experience, either good, bad, all the things that have happened to me and that I've done, to be able to show people, and I've probably always got this little agenda that, mental health is a really good way to go when they graduate. Because even like as new grads, their mental health is probably so far from their radar, most of them, that I like being able to highlight it as a really amazing place to work and a really, what would you say? I don't know how you'd say it. It gives you the warm and fuzzies.
Yeah.
It's a very rewarding place to work. It's a very rewarding practice area.
That's a great way of putting it. I love that. I love teaching it because it's a huge responsibility. You are impacting minds at a bigger scale versus working one-on-one with patients. You're always impacting people, but teaching also has that joy of, helping people. Like you see their little light bulbs go off, and I love that.
Yeah. I think it's been good too now that I've been there, sort of like seen 2 years, like we're a bachelor's degree, so it's a 4-year course, but like I've been there for 2 years of that sort of initial cohort now as well, and seeing them progress year to year is also something that's really cool. And like you'll see like, I remember that kid when I taught him and he was in first year kind of thing, and now look at him go. Like, yeah, it's kind of cool. I'm very much enjoying it so far. Yeah.
Oh, that's awesome.
No, I'm good.
Okay, so thank you, Brock. This was interesting. We took some turns. We talked about mental health. We talked about burnout. We talked about insurance, which it's like overwhelming, and we're just trying not to bash the whole country. Yeah. So where can people get more of you?
What would be the easiest? I'm pretty much anywhere that you can find on the internet. Probably the easiest place is just my website, which is just brockcook.com. That's got my podcast. You can email me from there. I'm also on Twitter at brockcookot. Occupied Podcast is on Instagram. I'm on Facebook. A lot of the networking groups you'll probably find me in. So any of the 4 OT groups, so MH for OT, OT for OT, AT for OT, there's about 50 of them, but I'm probably in most of them. I'm not hard to find.
Oh, awesome. We'll be sure to put everything in the show notes.
Yep.
So no one misses a thing. So my favorite question that I love to ask people, what is your most lit up self?
Oh, as in like what I like to do, or like a time in my life?
Anything that makes you alive, feeling alive in your most vibrant, radiant self.
The best Brock.
The best Brock there is.
The best Brock. I don't know if I found him yet.
Oh, it's kind of a good answer, though.
Yeah, that is a good answer. No, not that we judge.
I like doing things where I'm feeling creative. Mm-hmm. So generally my creative isn't like painting and drawing and that kind of stuff. My creative is like technology things usually. So like podcasts or videoing and that kind of thing. And I like trying to incorporate that stuff into my general day-to-day life. So like my students will get little videos and little audio recordings and that kind of stuff from me, just highlighting different things. Like I obviously started a podcast, and that was purely so I could learn more, just nerd out a bit around audio. So pretty much anything when I think the ultimate is when I'm able to combine that outside, because I do like to be outside. Yeah. A lot of my videos and stuff that I record from students, because our university is kind of surrounded by bush, trees and forest, not forest, but like bush. So a lot of my videos that I record for students will be out in the bush. I'll just go for a wander just to get outside for a bit and that kind of thing. So, and we live in a beautiful part of the country, so why not show it off a bit?
Yeah, I love that. It's combining nature, which is therapeutic for all of us, and getting out there and doing what you love. So thank you, Brock. Thank you so much.
Thanks.
Pleasure's mine. Thank you so much for having me.